Thank you all for joining us for our symposium today, Exploring Patient-Centered Benefits, the Value of Continuous Topical Oxygen Therapy. Also, you'll find on your seat a handout that has all of the NATROX topical oxygen therapy evidence. So you can scan the QR code that'll take you to our learning library, and you can find all of our evidence there. And don't worry if you miss any of this or you have extra questions. We will also be in our booth after the symposium, so please stop by, and that's booth number 120. So I'm Dr. Wendy Cole. I will be your moderator for this session. If I don't know you, I am from the US. I'm from Cleveland, Ohio. I am the Director of Wound Care Research at Kent State University College of Podiatric Medicine, and I also act as the Global Medical Affairs Director for NATROX Wound Care. I'm a podiatrist, and I've been a wound care specialist for over 22 years now. Our two speakers are very esteemed in wound management, and we're very excited to have them talk to you about their experience with topical oxygen therapy. Our first speaker is Professor Dr. José Luis Lázaro Martínez. He is a full-time professor at the University of Madrid. He has a PhD in biomechanics of the diabetic foot. He has a certification from the Fellowship Board of the New York College of Podiatric Medicine and a master's degree in health research from UCM. He spearheads the diabetic foot unit, and he's the coordinator of the diabetic foot working group within the Spanish Diabetes Society, demonstrating his commitment to collaborative research. And then our second speaker is Sister Liezl Naude. She's a clinical nurse specialist in advanced wound care and the founder of Eloquent Learning Health and Eloquent Health and Wellness. She has her degrees from the University of Pretoria, and she has a certificate in wound care at the University of the Free State of South Africa and a certificate in wound care from the University of Hertfordshire in the UK. I hope I said that right. And Liezl is also a wound care warrior, a wound care expert. She's on the forefront of wound management in South Africa. And she is part of the Wound Healing Association of Southern Africa since 2005. And she also established the official journal, The Wound Healing of South Africa. And her interest is in diabetic foot management, lower extremity limb management, and sports injuries. So I'm just going to give a brief introduction about shared decision making, and really the idea of shared decision making is really taking a patient-centered approach to wound care. And shared decision making, otherwise known as SDM, is really a transformative and empowering process that allows for patients and clinicians to really engage in shared decision making. And by collaborating with both parties, both the doctor and the patient, we can consider the patient's unique values, preferences, and then also allow us to educate them on the best available evidence. So a lot of us, we know that our long-term goal in wound management is most often wound healing, but sometimes our patients have short-term goals that are very important to them, possibly controlling of exudate or controlling of odor or decreasing pain or increasing function, because they can't go, to their house of worship, or they can't be with their family members because of the odor or the exudate of the wound. So taking their goals into consideration along with our clinical goals is really important. And having a shared decision-making partnership encourages patients to also take an active role in deciding what's the most suitable treatment, because we know that there are certain gold standards of care that, like a total contact cast or compression therapy, a 4-layer compression wrap, but maybe our patients can't tolerate that or they can't adhere to that, and then we sometimes label them as non-concordant or non-adherent, but really they just can't manage the dressing, or they can't, come to our clinics on a regular basis because they don't have transportation. So understanding where the patient is so that we could really prescribe the most suitable treatment will help us have a better understanding to the commitment of care and get them on board as a really important member of the wound healing team. So key aspects of shared decision-making is really taking that patient-centered approach, prioritizing their needs and desires in that decision-making process. Open communications, making sure that there's a clear explanation of the treatment options and really understanding the why. Sometimes we tell our patients, oh, we're going to do X, Y, Z, but we don't take the time to explain the why. And for them to understand the why allows them to really process the reasoning behind what treatments we're prescribing. Using evidence-based information for them to make the best clinical decision as well, so that they're part of that decision-making process, and allowing for some patient autonomy. They're allowed to make their own choices because it has to align with their personal values as well. So a mnemonic that I find very helpful is SHARE. So SHARE and shared decision making. The S means seek the patient's participation. H is help the patient explore and compare treatment options. A is to assess the patient's values and preferences. And R is to reach a decision with the patient. And E is to evaluate that patient's decision to make sure that they're making the best decision for them. So NATROX O2 really can help to support shared decision-making. It's an adjunct therapy that works with other advanced wound care modalities. It's a very easy-to-use device that supports the patient to continue their activities of daily living. They're able to remain mobile, and that increases their satisfaction with care and their quality of life as well. So our oxygen generator is very small. It's the size of a small cell phone. And like I said, if you haven't seen it or manipulated it, please come by booth 120 later. It creates a constant, concentrated oxygen flow that's delivered continuously to the wound. Through the electrolysis, it removes the oxygen from the room air, concentrates it, delivers it through the tube directly to the wound. As I said, it's wearable, so the patients can maintain their mobility. It can be really easily hidden by a pant leg or a skirt, or, you know, if it's on the upper extremity, a sleeve, so they don't even know that they have it, or people can't see that they are wearing a device. It doesn't make any noises. Well, you know that the oxygen is flowing when the green light is flashing, but there's no beeping or alarms that'll sound in the middle of the night like some other wearable devices. It has 2 interchangeable batteries. They last for 24 hours, so you have one battery on the charger while the patient's using it, the other one to really power the device, and then they change it out once a day. It's adaptable, so it can be used with other therapies. It could be used with cellular tissue products. It can be used with collagen. It can be used with multiple secondary dressings. It can be used under multi-layer compression therapy or under offloading, even with a total contact cast. And then there's proven efficacy. There's a lot of published literature in which you have on your seats so that you could look into that more, but there's RCTs and meta-analyses that really support the use of topical oxygen therapy in chronic wound management. So that is my introduction. I'm going to turn the microphone over to Professor Martínez, and we're going to hold questions until the end of the symposium. So thank you for your attention.
Good afternoon, everybody. Thank you for the invitation, for sharing our experience here with the NATROX technology, and especially with the continuous topical oxygen therapy. My lecture is mainly focusing in the indication. So I used to say that there is not a bad therapy, there is a bad indication. And this is why I think it's very important to define what is indication for selecting the right patient at the right moment. So for sure, this is a question that we have when we are managing any diabetic foot ulcer, and we have a patient in front of us. This is the question that we are used to do. Is the ulcer is healable? But the question can be generally, right? Is any diabetic foot ulcer healable? So for sure, we know no, and especially because there is an impairing wound healing that is related with the main concern is ischemia. Ischemia is affecting the prognosis for the ulcer healing in the majority of the case. At the same time, we know that the standard dressing is not enough in the majority of the patients with diabetic foot ulcer. So that means that probably we are spending resources, time, without any expectation in many of the patients. So this is a result coming from a meta-analysis. And in this meta-analysis, they demonstrate that after 6 months of therapy, only 30% of diabetic foot ulcer was healed. So that means that the majority of the patients are still open with the ulcer open. So when we are going back to the standard of care, so that is something that nobody are challenging. Everybody agree with the standard of care. So there is the main pillar for treating any diabetic foot ulcer. So that means offloading, revascularization, treatment infection, managing diabetes and its comorbidity, and finally local care. But among this standard of care, there is some variabilities. So something that we need to do is going back to the recommendation for the international guidelines. This is coming from the International Working Group Diabetic Foot that is included in the local care charter 29 recommendation. But unfortunately, the majority of them is don't use. Don't use is because there is not enough evidence and there is a risk for complication when you are using, and especially the expectation for using this kind of therapy is not 100% sure. So that is the recommendation. But coming back to the standard of care, what is the standard of care for managing diabetic foot ulcer? And I used to put this paper for David Astron, so that is the mentor of everyone working in diabetic foot, because I think this is very, very conclusive about it's not what you put on, but what you take up. And this is the main recommendation for treating every diabetic foot patient among the world. That means the right, you are taking not be able to sue and offloading. You are relieving, you are taking pressure, right? This is the main standard of care, but mainly for plantar location ulcer and mainly for pure neuropathy. But what happened? The problem is the standard of care or the implementation of this standard of care has some variations. So according with the literature, there are more than 28 different standards of care. So that means standard of care is Babel Tower, right? So that means for some people means something, for other people means another thing. But very important, what is the patient profile that we have? So unfortunately, we don't have updating data for the general profile of patients with diabetic foot ulcer in Europe. This is a paper coming from the Eurodial in 2008. And in 2008, we know that 50% of our patients with diabetic foot ulcer has ischemia. But currently, we know that this is even worse. But in a neuroischemic condition, how to be sure the ulcer is healable, even after revascularization? This is the main challenge sometimes. So, and we are traveling among the time with different concepts. The first concept is below the knee peripheral arterial disease. The second concept is below the ankle. The recent concept is the small arterial disease. And now we are concerning about how is the distribution of blood in the fitted patient with diabetes. The thing is that probably we are talking a lot of time, many years ago, about ischemia. But the problem is not only about the ischemia. The problem is not only how the blood is delivering to the vessel, through the vessel to the foot. The problem is still how this blood is distributing through the foot, right? So we can say that we now a new concept. One concept is problem with transmission, so that means ischemia, mainly ischemia, affecting the macro vessels, so that means arteries, and another problem is distribution. And I used to put this example that is very simple for people. You are living in an apartment tower and you don't have water in your apartment. You can have problem with the distribution inside your apartment, and you can have problem in the transmission, problem in the water delivery in the street, right? It's similar to the food. If you had a problem with the transmission, for sure you have problem with distribution. But even if you had a very good transmission, you can have problem with distribution. That is a very common thing in every patient with diabetic foot, even if the patient has neuropathy, because autonomous neuropathy is affecting distribution of the blood. So that means, so even if you are assessing patient for the vascular status, the only way to be sure if the patient is healable is taking data coming from microcirculation. And that is why in the international guideline, they are including that the only way to be sure if the patient is healable is taking values for microcirculation. That are mainly TCPO2 and skin perfusion pressure. and this is a paper that we recently demonstrate that the DFU is a strong indicator about the prognosis of the patient. Okay, so if we have neuroischemic patient mainly, if we have patients with problem with transmission or distribution of both, right? How to be sure of the type of the debridement to do, how to be sure if we are taking, if we are putting dressing that are working with this kind of patient, and how to be sure if the rate of the responding of the patient is giving me a right information. Unfortunately, we don't know. But something that we can say, as this is my personal opinion, that the era for neutral dressing is over. So I'm so sorry. But I think especially in neuroischemic patients, the era for neutral dressing is over, and the demonstration coming from the literature say that, right? Remember, 70% of patients are still open after 6 months of therapy. So what about the new therapies? Though many people, and especially in the medicine area, people used to be skeptic with new technologies. I don't know why, but this is something that we have in mind. When someone is knocking your door, trying to introduce a new therapy, the people are skeptic, probably because there is a lot of marketing message behind this, right? But the good things with some new therapy is that it's supporting with the evidence, and that is why topical oxygen therapy is now recommending for the managing patient with diabetic foot. That is new because it's included in the last edition of the international guideline, and I can say that some years ago, this is something that the people are challenging. But now it's not a question of challenging. Now it's recognizing for the international community. Now the international community and the stronger evidence group in the world, as is International Working Group of Diabetic Foot, is recommending you the use of topical oxygen therapy. The problem is, okay, we can use topical oxygen therapy, but it's necessary to use in every patient at every moment? For sure not. But the question is how to select the proper patient at the right time. That is an important thing. For sure, in the clinical parameter for indicating the topical oxygen therapy, we have to take into account patient characteristics, so patient assessment and wound assessment, and inside wound assessment, some characteristics. Trying to do simple, right, and to be pragmatic, right? How can be the main indication for use continuous topical oxygen therapy in diabetic foot. First one, non-responding diabetic foot ulcer. That is related with the previous statement. Remember, neutral dressing is over, so that means when you have a non-responding patient, it's time to think something more. But remember, it's time to think something more with the evidence support, right? Because otherwise you can use a lot of things that you are not sure that is working in this kind of patient. Second, neuroischemic patient. Neuroischemic is a special condition where probably wound area reduction is not working. Not working means that probably if you are assessing what is the wound area reduction in a neuroischemic condition can be different, because this percentage, 50% of wound area reduction after 4 weeks, is coming for studies making in neuropathic patients. So neuroischemic is different. So for my opinion, neuroischemic can be a first line of therapy. So that means first line. I can use for the very beginning, for day 0, the topical oxygen therapy in neuroischemic patient. And remember that you have here 2 kinds of patients. Ischemia, that means peripheral arterial disease, and hypoxia, that means distribution, especially for small basic disease. Another important thing, transition. That's a transition therapy. So thinking in patient journey, this is very important, because sometimes we are thinking in something that you have to apply for the day 0 to the end of the wound healing process. That is absolutely wrong, right? You know that the ulcer need different things and different approaching among the therapy, right? So probably when you are treating patient in day 0, the patient needs different things than when you have a patient close to epithelialize, right? And you need different therapy. For this reason, I think something that is not covering, that is a current gap currently, is when you have a patient treating with a negative pressure wound therapy. For instance, you have a patient with foreign infection, or you have a patient with soft tissue infection after the surgical debridement. The recommendation is to use negative pressure. But what kind of therapy are transferring to? So that means when you are removing negative pressure, what is the next therapy that you are using? Usually neutral dressing. And this is like you are changing people driving in a Ferrari and you are riding in a monkey, right? That is different. They are moving, but at different velocity. And that is something that we realize, right? So I think is another important indication. Deep tissue exposition. This is challenging and very common diabetic foot, tendon exposition, bone exposition. Sometimes negative pressure is not able to cover enough because Symposia condition is not able to get a good granulation tissue formation. So for this reason, I think you can use a topical oxygen therapy. Post-amputation, this is another indication. Incision descent, very common in surgery in diabetic foot, and especially heel ulcer. Heel ulcers has a special condition because vascularization in the heel is not the same in the other part of the foot. They have a poor vascularization and sometimes it's a challenging patient with ulcer in the heels. So I'm going to start with the more clear indication in my opinion, neuroischemic. If you have a neuroischemic patient, the first line of therapy could be topical oxygen therapy. So that means Wi-Fi 1 and 2, right? So that means this kind of patient that are neuroischemic. Why you are thinking to treat the patient with a neutral dressing? This is absolutely wrong because the probability that the patient is going to respond is very low, right? But it's the opposite. But listen, the recommendation for the guidelines say, okay, no, start to use a standard of care, and if the patient is not responding, you can use the coadjuvant therapy. But in my opinion, it's a wasting of time. In a neuroischemic condition, this patient used to go bad if you are using only neutral dressing. That is an example. This is a patient with a neuroischemic condition after revascularization. Listen, this is the vascular status of the patient. See the ABA, see the TBA, see the TCPO2. This is a very, very bad condition, but it's after revascularization. Because even if the patient underwent a revascularization, the patient is not going back to the normal condition. It's still a neuroischemic. For this reason, you can select patient after revascularization as a good candidate to use topical oxygen therapy. You can see here one with after surgery, 4 months after surgery. Remember the meta-analysis. After 6 months of therapy, 70% of patients are still open, so that's means the patient is not responding. So listen, see how he's responding when we are applying the topical oxygen therapy, in this case in NATROX. You can see here, after 8 weeks and healing by 20 weeks. The people can say, okay, 20 weeks is a lot of time. Yes, but you are spending 16 weeks without not progressing. So that means this is the explanation about how it's useful, this kind of new therapy in the neuroischemic condition. You are able to save the limb, you are able to avoid a lower limb amputation in a very bad condition because the patient has ischemia even after revascularization. So, bone descent, that is very common in our medium, right? Because this kind of patients sometimes underwent a surgery for different purposes. The main indication is osteomyelitis. In osteomyelitis, you have to remove the bone infected. We are performing conservative surgery, but even offloading surgery, that is another indication. But the rate for descent is very high in this patient because the vascular condition is very, very bad. Listen, this is the patient after the surgery, and you can see here how the patient has this descent with the bone exposed. So what is the option there, right? You have to perform another surgery, you have to apply negative pressure, and you have to wait if the bone is covering. We decide to treat the patient with topical oxygen therapy and see how this is the day 0. After 4 weeks, the bone is covering with a marvelous, a very good granulation tissue. This is the only thing that you can see only if you are using negative pressure. But honestly, I had to confess you that it was aesthetic. So the first time that I put this therapy over a bone, I never expect that it's able to cover. But see in the picture how the bone is covering with a very nice granulation tissue, and finally the patient is closed. So this is another important and strong tool that you can use in this kind of complication when you have the bone exposed, of course, without infection. This doesn't mean osteomyelitis. Tendon exposed. This is another common thing. This is a patient that are coming to our clinic after soft tissue infection. So usually after this soft tissue infection, remember dorsal of the foot is a common location for pus, for the upset, right? This is after debridement the patient. The patient are coming to our clinic with an indication of the lower limb amputation. So that means that is usually happen. So after the debridement, the general surgeons are offering the patient only lower limb amputation. And why? Because the patient has ischemia and they thought that probably with this condition it's not possible to save the limb, right? This is, of course, the patient, we did the revascularization because the patient has ischemia, but you can see here how, of course, this toe is over because it's infected, but you can see here the outcome after 12 weeks, right? So all the tendons are covering, so the ulcers are reducing, so we get a good granulation tissue, and we can offer now a solution for the patient. The patient is not finishing because it's currently under therapy, right? And we don't have the final picture, but it's a very good example to see how this therapy has the capacity to cover tendon exposition. That is very interesting for us. Another spectacular response for topical oxygen therapy. This is a lady that came to our clinic in a very bad condition, suffering a renal complication and a vascular arrest. And for this condition, the patient underwent an metatarsal amputation. And we performed an calcanectomy because the patient came with osteomyelitis. We applied negative pressure wound therapy with distillation, and this is the aspect that the patient has after 5 days of negative pressure with distillation. So I had to confess, when I saw the patient say, okay, this is not possible to save the limb, right? Because you can see how there is necrosis in the edge. This is bone exposed, calcaneous bone, and we are starting to apply, and this is 4 weeks after topical oxygen therapy. If you are talking me this, I think 2 years ago, I say, okay, listen, I don't believe you, right? But this is the spectacular response that the patient has for the application of topical oxygen therapy. So in a comparison, it's more or less the same response that when you are using negative pressure wound therapy. But in this case, negative pressure wound therapy is contraindicated because the vascular status of the patient don't allow to apply this kind of therapy because it's provoking local ischemia, right? And this is the combination. So, in conclusion, I think that evidence-based approaching for diabetic foot ulcer guaranteed less patient outcome disparity. So that means this is a claim for the evidence support. Probably in the exposition booth, you are receiving a lot of message for the holy water, right? That is the solution for your patient. But listen, asking always for evidence supporting. Topical oxygen therapy now are supporting for the International Working Group Diabetic Foot. That is another important conclusion, that is cover a current medical needs in diabetic foot patient. Remember, neutral dressing is over, neuroischemic condition is very common, and in this case, sometimes the normal solution that we have, in this case, for instance, negative pressure is not covering so well. So topical oxygen therapy demonstrates better patient outcome comparing standard of care, right? And remember what the standard of care means. So probably currently in the 21st century, standard of care is different 1 century ago. So if you are doing the same things 100 years ago, probably you are getting the same result. The same result means 70% of your patients are still open after 6 months of therapy, okay? So, and for this reason, we can say that it's a cost-effective therapy because it's able to get better outcome in patient, increasing rate of patient healed, and reduce healing times. Thank you for your attention.
Hello, everyone. Thank you for that, Prof, for that explanation. I think those photographs speaks louder than anything else and all of that. So it's such a privilege to be part of you guys here and to be here at EWMA this year. For me, in more than one reason, and I'm going to share a little bit of my story with you as well. I don't look like that photograph anymore because this is what happened to me. So 6 months ago, I'm traveling to the US to go to a conference there. I developed Stevens-Johnson syndrome. Have an allergic reaction on the plane while using a nasal spray and not realizing what was going on, as well as the physicians that saw me at the ER did also not recognize the symptoms. They thought I had shingles and a bacterial facial allergy. Needless to say, as you can see here, the size of my face and everything is double what I am now, and I developed more than 31% total body surface area burns, of which my face was the worst. And I also lost all my mucosal membranes in my body, literally. I coughed my lungs out. It's not just a saying, it can happen. Okay. But by the grace of God, a week after that, or basically a week and a half, I was able to attend a hockey game for my daughter in South Carolina. So I was bandaged all over, but I could watch a hockey game. The problem was that I was on high dosages of cortisone before that, and I didn't sleep because of my wounds. So I developed hypomania. So I was a crazy headless chicken running around like a mad person in that state. And we often forget or we don't realize what the implications long-term are for patients. It's not just the acute phase in wound healing. The last photograph here is where I'm back in South Africa with my family. At that stage, I couldn't really walk anymore. I was really ill. And back in South Africa, I healed. It's my plastic surgeon working with me, my lymph therapist. And I went back to America in December. I did develop PTSD, which was really severe. Part of going back to America and confronting it actually triggered a lot of things, but also helped me a lot. And for the last 3 months, since December, I've been in a lot of therapy. And I'm glad to say I'm here. I don't have PTSD anymore. I do get anxious still at times, but I'm talking in front of all of you, whereas 4 months ago, I could barely be in a room full of people, okay, which is just by the grace of God. So for me, this is about celebrating life, celebrating friends. And you know what? Wounds are not the end for patients. Wounds are not, it's sometimes the beginning. My journey is about me being a caterpillar with burn wounds turning into a butterfly. And irrespective of scars, of which I am very graciously having minimal, we can make an impact in our patients' lives. So the purpose of my talk is to literally get you to focus a little bit on something else. Why do we use innovations? And what is the purpose of using new things? Why do we want to use this with our patients? You're not going to try something new if it's not going to make a difference. Otherwise, it defeats the process. It's also, what is the impact on the well-being of the patient? And what about the patient's story? How did they experience it? Because as a wound clinician or as a healthcare professional, we've got a certain idea of what a product needs to do for us. But have you considered how your patient will experience that product? What's their viewpoint? In my healing process, I developed severe keloids and I had contractures and all of that. I never ever thought about how I would feel or how does it feel when keloid starts developing. Have any of you thought about that? How does it feel when keloid starts to grow? To me, it felt like I had an alien underneath my skin crawling. It was terrible. And then as it progressed, it was like a volcano erupting and hot lava flowing out. That was my experience on keloid. The difference was I was not only just a patient, I was a clinician as well. So I could make plans on the spot, and I could use dressings, and I could use colleagues, and I networked with that. So do you know what that is? That's the first wheel, 40 BC. That's where innovation started. How awesome is it that this device looks very similar to a wheel? We've progressed. We're going forward. We're using maybe old things, but in a new way. So why do we use these innovations? Number one is we want faster healing times. We want that patient to be back in society, getting on with their life, being with family members. We want to reduce infection rates. Because one of the worst things for a patient is recurrent infection. In my treatment, we wanted to prevent secondary infection because that was the risk and that was what's going to cost me my life. Your patient comfort. Can they wear this device or whatever bandage you're using? Is it comfortable? Is there a better long-term outcome? It's not only about getting that wound to close. What about the scarring? What's going to happen with that patient afterwards if there's contractures or if there's deformities or several other amputations? What's their quality of life? It's also about cost effectiveness. And sometimes I hate the word cost effectiveness because what is it really? Is it to have a cheap dressing or is it overall that we're actually getting the costs down and that it's better for a patient? Okay. It's also about personalized care. Can I tailor make what I've got to work the best for my patient? And then very, very important is the psychological well-being of your patient. How are you looking at that? Or are you even considering that when you decide upon a treatment? If we look at the dimensions of wellness, there's so many things, emotionally, occupationally, intellectually, the environment. What about your patient's finances? What about their social activities? For one of my patients, it was important that they will be able to just go to the mall and do some shopping without having a wound that's having an odor all the time or X-ray dripping all over the place. Okay. These things matter. So let's look a little bit at psychological factors. Okay. Here a lot of things will matter. Health and literacy awareness is so important, and the patient's awareness about what are you using, how it's being used. A lot of patients are skeptic when it comes to new innovations. Oh, we've tried that before, or no, there's nothing new. We've used iodine and gauze, it's been working for ages, why should I choose something new? So that is also limiting ourselves as professionals because of this. Past experiences. Oh no, I did use a tube of oxygen one time on my wound, but it didn't really do much. Why would this device now make a difference? What's different to this? And then also, what's the perceived risk versus the benefit? Will something go wrong if I try this new innovation? Or is there more benefit to this? Then you need to consider also the social and the cultural factors. We all come from different countries, different places in the world. South Africa is a very unique environment. We've got 12 different languages, 12 different cultures. And when we talk about cultures, it's not about your skin color. I'm a white South African, okay? But I'm still an African. And we tend to look at skin color to define ourselves. That's not what defines ourselves. It's your cultural background and who you really are. Family and peer options are also there. How's the family perceiving the therapy? Are they buying into what you're offering for your patient? And then, like I said, their cultural beliefs. Maybe for them, this is something so foreign that they can't put that into their culture. And at the same thing, if you've got a patient in a rural area, what about electricity? How are you moving forward with that? In South Africa, we've got a very unique concept called load shedding. So that's not like in the diabetic foot where you offload the diabetic foot. This is completely different. It means that we don't have electricity all the time. We share the electricity. So we have moments of darkness, and sometimes it can go on for days. Okay. It's better now, but we hope there's a future for us in South Africa. It's also then about the medical and clinical factors. How severe is the wound? What type of wound is it? What's the accessibility and the cost? And what about regulatory approval and credibility? And those are things that you need to consider before you try a new innovation. Okay. So it's also the technological and ethical factors. So how easy is it to use and to apply? Can it be personalized to the patient's needs and customized? And what about ethical and religious concerns? Because we need to be sensitive about that as well. So I want to introduce you to a few patients of mine. I'm going to share 2 stories and then some other photographs as well. This is Mr. Kissendoof. I've got his permission to share his information with you as well. And he literally said, I needed to be part of my healing process, having my doctors all being on the same page. And that's a very important statement. in understanding what was going on. Faster wound healing and a better long-term outcome, and I also needed to get back to work as soon as possible and out of hospital. This was his foot. So we started at week 0. He was before this for a long time on negative wound pressure therapy, and he was just getting stagnant and not moving forward. And you can see here, within 12 weeks, we had complete closure of this wound. 14 weeks, nothing gone. It's now been almost 2 years since this. No breakdown, no additional scarring, no keloid formation where we had the scarring. So really a great result for this patient over and all. And we do follow up with these patients on a regular basis. That's not going. Okay. I also want to introduce you to Dylan Beneke. Dylan is a 26-year-old quadriplegic patient. As you can see here, he's got pressure ulcers all over his body, literally. But his story starts with load shedding in South Africa. Because there was no electricity, his backup generator failed, and thus his mattress failed to do offloading. And he was lying on that hard surface area for a long period of time on several occasions. And this resulted in several pressure ulcers developing on there. Dylan's biggest challenge for this was that, or the biggest challenge we faced was, we need to get him back in his chair as soon as possible. He needs to feel alive. He needs to be part of his family, and he cannot be all the time just lying in bed, not doing anything and staring at the window. And you can see this is the position that he's usually lying in. That's not much of a view. So we started with Dylan, and you can see he had already this sacral pressure ulcer for 2 months. But look at that, 8 weeks, 2 months, and that was right up until the bone. Okay, that was bone exposed, all of that, and we got complete closure. Till this day, he didn't redevelop that pressure ulcer. So the tensile strength of the wound is much more superior than what I've previously experienced in any other devices that I've used. There's still a lot that we can say about that, but there's a lot of studies out there that will show you more of these details. And I would like to challenge you, go and look at the reading material and read up on what we've given you and on the other big studies that's been done. This is another diabetic patient, and Prof has already spoken about the diabetic patients. And this may seem like a small wound, but the problem is that small wound has been there for 12 months, getting bigger, getting smaller, getting bigger, getting smaller. So to have that completely healed by 17 weeks, and it's still healed, means that we've got good quality skin, no additional surgery was done. And this makes a big difference to our patients. This is a different case as well. This is a patient with a complicated full thickness burn on the right thigh. So during the proliferation phase, we started with the NATROX device. And significantly, what was the difference here was the quality of the scarring. And yes, it's not the most beautiful wound out there or scar that you can see, but if you look at where she came from, the scar was more supple, it was easier moving around with that, there was no lasting effects. And for the patient, the pain in the treatment, the decrease in pain was really the biggest difference for her. In all the patients who could feel, who didn't have neuropathy, it was very recommendable to say within the first treatment, we had a response to say that pain has decreased. And that is really something significant in these studies. This is another paraplegic patient of mine who had this wound for 144 months. That's a few years. Okay. Not healing, getting a little bit smaller, still going on, and you can see the calcification as well on the tissue over there. It is not a good, it's literally like a dead wound that's just sitting there. We started with topical oxygen therapy, and you can see within 4 weeks, look at the granulation tissue. Good quality granulation tissue filled the gap completely, and you can see ongoing how that wound kept on healing with regards to this therapy. For me, a win is when I can see good granulation tissue. That means I can start breathing, we're moving on to the right direction. Okay. So when we look at this treatment, you need to ask yourself, are we achieving the following? Are we getting faster healing times, yes or no? Are we reducing infection rates? Because the longer the wound is there, the higher the risk for infection. Is it more comfortable for the patient? Are they coping better with that? Is there better long-term outcomes? Is the scarring in the end better? And believe me, if you've gone through what I've gone through, scarring was one of my biggest issues in a sense, because my face is what you see when I talk. And I was like, how am I going to be able to stand up on a podium and speak to an audience if I've got severe scarring? But I've also learned the treatment modality that you choose in the beginning have an impact on your scarring in the end. By using something like topical oxygen therapy, you already have an impact on what your patient's scarring will be in the end, because we know what oxygen can do for yourself, for your patients. Cost effectiveness, saving costs in the long run, saving patients from coming back again and again and again for the same type of wounds. And also that personalized care, having the patient being part of your treatment program, where they change their batteries themselves. And some of my patients I taught how to do their own dressing changes with the device. It empowers patients to do self-care even. And it's also about that psychological well-being. Are they able to actually stand up and say, I am alive, my wound's healing, I can be somebody contributing to my community again. When we look at all of this and we combine this, this is when we move forward. This is when we address the concerns of our patients. So why do we innovate? To make a difference. Otherwise, why are we here? Why am I here? I firmly believe we can change lives. And if you change one person's life for today, even if it's just by giving somebody your smile and they smile back at you, you've changed their lives. Okay. That's making a difference. So how fortunate are we to have technology that can assist us in making a difference in our patients' lives? I think the next one's the video.
I'll invite both the speakers up to the stage. I'll play a short video and then we'll open.
Thank you very much.
I had 6 months of wound treatment with little results. Everything was made harder. Anything I did was just an effort to do. When I finally got this, it was really a miracle. With all the different things you tried, everything, it was a miracle to me to be without pain. I'm 91, I think it gave me a new life. It just worked. It worked. And I was one of the lucky ones to get it. Thank you.
All right, anybody have any questions for our speakers? There's a microphone in the center, or yes. Nancy, do you want to get the microphone? Thank you. The gentleman up front here.
In the people's lives. So my question is, what about the ischemia pain or resting pain? I mean, is
So-
there any change with that?
Yes, so anecdotally, we have seen quite a bit of pain reduction in our patient population. There is a small study out of the University of Karolinska that also looked at pain in patients with mixed etiology lower leg ulcers, which showed a significant reduction in their pain, and also, maybe more importantly, a significant reduction in opioid utilization. So we're trying to elicit that specific mechanism of action. So we have some clinical trials that are underway. But I'd like to also have our speakers interject their personal experience with their patients as well with pain.
So in our experience, it's a very good pain controller. So that's mean, so sometimes it's not possible to relieve all pain the patient. So remember as well, I think standard of care. So in ischemic patient, the patient has to be revascularized. Otherwise, it is the meanwhile, you can use this technology and you can reduce pain. So the majority of our patients feel that's reducing pain very quickly after the application. So I think it's a very good coadjuvant in this field.
I've experienced the same, specifically with my arterial patients, is they definitely decreases the pain and their opiate use is much less. So there still needs to be a lot done about that, but in the anecdotal evidence so far, there's definitely a positive change.
Question up front here.
Thank you for the speakers. Great presenting. I'm just wondering about the limitation of this method.
Well, there are contraindications. So any active infection, active osteomyelitis, if we believe that the wound is caused by cancer, other things such as that, there are some contraindications. Closed incisions right now is a contraindication as well. As far as limitations, clinically, have either of you found any clinical limitations?
So I can add necrotic tissue when you have necrotic tissue because you have to debride. So, but again, it's a standard of care. So that means if you are applying this technology in an osteomyelitis, this is not way, right? You have to treat before. So that means that the patient has to receive antibiotics and the majority of the cases surgery, right? If you have a necrotic tissue, you have to remove there, right? So that means that in general, if you have an infection, you have to treat. So standard of care is the basement. This is something that you can apply after. Then you have under control the ulcer, any etiology. Yes, it's not something that you can put in the wound in any condition. So you have to manage the wound according with the standard of care. So that means this is a venous ulcer, the patient needs compression. It is a diabetic foot ulcer, the patient needs offloading. So this is not replacement for nothing. So this does mean that you have to treat the patient with the same standard, but additionally, you are using this therapy with this indication, you can get better outcomes.
It's not an or, it's an and, basically.
No, it's an
It's
adjunctive therapy. So
adjunctive
see
therapy.
that as that. So see that is you've got your basket of care that you've got, but you've got this that you can add onto it to increase healing rate faster. And you still, like I said now, just keep your basics there. If there's a vascular problem, you sort out the vascular problem. If there's infection, you need to sort out the infection. If pressure is the problem, wherever it is, there's too much pressure on the diabetic foot, or like a lower leg ulcer, venous leg ulcer, where you don't have enough pressure and there's not compression, first do that. But you can apply this modality while you're putting a patient in a total contact cast. You can apply this modality underneath compression as well. So it's wound, you put that as your interface directly onto the wound, and you use your silicone foam dressing, for instance, on top of that. So see that just as an add-on to make things go much faster.
We don't recommend anything with petroleum base to go on the wound because it will decrease the oxygen flow into the tissues. So that would be another thing to consider. Creams and lotions, we're not sure how it penetrates through those as well. So if those are applied on top of the wound, and then the topical oxygen, we're not sure, the penetration level. But as Sister Liezl says, we need a semi-permeable secondary dressing on top of it so that it helps for the management of exudate, but then also helps to lock some of the oxygen close to the tissue surface as well. More questions?
So the wheel of the device is a bit small. If you have bigger wounds, do you put multiple or?
So you can, or you can move the wheel around at each dressing change. So a larger venous leg ulcer, what I typically will do is move the oxygen delivery system, the wheel, in a clockwise fashion at each dressing change. Do you have any other experiences with larger wounds and
No, I do similar.
same thing? Same thing?
Yeah.
Yeah. And you can use multiple oxygen generators and oxygen delivery systems, but we can't put a Y coupler on because we're not certain that we would deliver the oxygen at the same concentration at the same rate. So, you know, if they have bilateral wounds, you might need 2 devices.
I've read that the oxygen is made from water molecules. Does it end, or do you fill it, or how?
No, so it just takes room air, and through an electrolysis process, it cleaves the oxygen, concentrates it, and then it delivers it through the tubing.
That's a good question. If we consider oxygen as a drug, excuse me, is the treatment titratable?
So we just deliver at a constant concentration. It's 11 milliliters per hour. And all of our studies have shown great efficacy at that concentration. So I don't know, because that's the concentration that we use and that has been clinically effective and tested. So, certainly. Any other questions? No? Going once, going twice? Well, we really appreciate you coming out to our seminar. And again, our booth number is 120. And I'm getting a high sign. Here you go. Here's our booth number. And we're going to be in the booth later after this. So if you think of any other questions, or you just want to come and play with the device and hold it in your hand, please come by and see us. So thank you very much.
Thank you.